Now we're going to go through the kidney. How does the kidney absorb calcium? Here are the tubules. 60% of calcium is reabsorbed in the proximal tubule, another 20% in the thick ascending limb, where furosemide works, another 10% in the distal convoluted tubule, where the thiazides work, and 2% in the collecting duct. Here's the proximal tubule cell. 60% of filtered calcium is reabsorbed through the paracellular pathway. Paracellular just means between two cells. Calcium gets absorbed with sodium and water through solvent drag. When you absorb sodium and water, you reabsorb calcium along with it. So if you're volume depleted and you're reabsorbing salt and water, you're going to reabsorb more calcium. Your calcium level may be high when you're volume depleted. Therefore, the treatment for hypercalcemia is normal saline. Of course, you're going to prevent the proximal reabsorption of calcium. Calcium absorption here is not under the regulation of any hormones. Parathyroid hormone and vitamin D have no effect on calcium absorption here. The thick ascending limb. This is the thick ascending limb of the loop of Henle. This is where furosemide works. Furosemide competes with the sodium 2-chloride potassium channel. It interferes with the chloride component, the NKCC2 channel. So if furosemide was not there, normally sodium 2-chloride and potassium will get reabsorbed. The sodium and the chloride get extruded over the basolateral membrane by these pumps, the sodium-potassium ATPase, or these chloride channels. The potassium gets kicked back out here into the tubule lumen through this renal outer medullary potassium channel, ROMK. This creates a positive lumen charge. This positive charge is the driving force for calcium and magnesium reabsorption paracellularly through the tight junction regulated by paracellular, which is encoded by claudin 16 and 19. This is a passive paracellularly reabsorption driven by a positive lumen created by the positive charge that potassium created. If enough calcium gets reabsorbed here, this calcium sensing receptor detects that there's enough calcium in the blood. The calcium sensing receptor gets activated. This turns off parathyroid hormone. It stops further potassium release here at the ROMK channel. If potassium does not get excreted here back into the tubule lumen, it will prevent further calcium and magnesium from getting reabsorbed. It will further prevent sodium 2-chloride and potassium from getting reabsorbed. You will start to lose salt, 2-chloride and potassium in the urine, and you'll start to waste calcium and magnesium when there's activation of the calcium sensing receptor. Now, there is a genetic defect that causes an activation of this calcium sensing receptor. The body thinks there's enough calcium around. It's called type 5 Barter's. There's activation of the calcium sensing receptor, preventing further potassium loss through the ROMK channel. You will have wasting of calcium and magnesium and wasting of salt. If you're losing salt, you will have hypotension, and hyperreninemic hypoaldosterone state. The patients have hypocalcemia in the blood because they're not absorbing any more calcium. Aminoglycosides can do the same thing. Aminoglycoside antibiotics can cause an activation of this calcium sensing receptor, similar to type 5 Barter's. Patients can develop calcium and magnesium wasting along with salt wasting. When there is an inactivation of the calcium sensing receptor and the body thinks there is not enough calcium around, you continue to reabsorb calcium. Your parathyroid levels will remain elevated. Patients have hypercalcemia. Urinary calcium levels remain low in this state. These patients do not develop kidney stones. They actually have hypocalciuria and hypercalcemia. This is the syndrome of FHH, familial hypercalcemia, hypocalciuria. It's a genetic defect. It's an inactivated mutation of the calcium sensing receptor. Lithium has the same effect as FHH. Lithium doesn't completely inactivate it. It raises the threshold for when the calcium sensing receptor will be activated. It kind of dulls it. Lithium takes a much higher calcium level to activate the calcium sensing receptor. Patients on lithium can develop hypercalcemia and hyperparathyroidism due to the inactivation of the calcium sensing receptor. The distal convoluted tubule. Here we are at the distal convoluted tubule. This is where the fine-tuning of calcium regulation occurs. So far, in the proximal tubule cell and in the loop of Henle, calcium reabsorption followed sodium reabsorption. Here in the distal convoluted tubule, calcium reabsorption does not parallel sodium reabsorption. This is the cell where thiazides work. Thiazides block the sodium chloride channel. If you take a thiazide and dump sodium and chloride into your urine, you can reabsorb calcium. You can give a patient a thiazide for kidney stones because it helps reabsorb calcium. Calcium is reabsorbed via active transport through the TRPV5 receptor, the transient receptor potential vanilloid subtype 5. This receptor is under the regulation of parathyroid hormone and vitamin D. Calcium gets reabsorbed through this channel. It takes the cal-binding ferry across the basolateral membrane and it gets kicked across the basolateral membrane through the sodium-calcium exchanger or the calcium ATPase. There are certain hormones that affect the TRPV5 channel activity. Estrogen. We know that premenopausal women are not losing calcium, and they're not losing calcium because they're reabsorbing calcium in the distal convoluted tubule. Estrogen is protective. Vitamin D and parathyroid hormone also increase TRPV5 activity. Alkalosis. When your patient has alkalosis, they reabsorb calcium. Clotho and tissue calcarein which activates bradykinin 2 receptor, also increase TRPV5 activity. TRPV5 is the gatekeeper of active calcium reabsorption. So what does the kidney do on a minute-to-minute basis to help us with our calcium levels? If we have a decreased calcium level, this inactivates the calcium sensing receptor. It causes increased parathyroid hormone release. We then increase our paracellular calcium reabsorption in the thick ascending limb of Henle. We also have increased TRPV5 active calcium reabsorption in the distal convoluted tubule. If your calcium is low, within minutes you reabsorb calcium in these two segments of the kidney. The proximal tubule is where the 25 vitamin D gets activated to 125 vitamin D. This helps calcium reabsorption in your gastrointestinal system.